At Axxess, we believe that teaching what we learn helps everyone to grow. You can count on Axxess to continuously create and present content to help your staff and your agency thrive in today's quickly changing environment. Before we begin, I'd like to share a little background about Axxess. Axxess is a technology company that provides software for health organizations to efficiently run their business. We empower healthcare companies with an easy-to-use, cloud-based software that integrates all aspects of their operations so that they improve patient outcomes while growing their business. We are the fastest-growing home health technology company in the country today, and also the #1 recommended home healthcare software by users just like you on Software Advice. Over 90,000 users log on to Axxess daily, representing over 1,800 agencies serving over 500,000 patients across the country today. Axxess has achieved many firsts in the industry. We are the first and only home healthcare technology company approved to award CEUs by the American Nurses Credentialing Center. We are the first and only company to have a native mobile app that works on both Apple and Android devices. And Axxess is the first software company approved to conduct CAHPS patient experience surveys. Now, as promised, let's start today's webinar so we can give you the knowledge to help grow your business.
Hello again, this is Jennifer Gibson, registered nurse with Axxess. I am coding and OASIS certified, and today we're going to talk about part 2 in our 12-part series called Navigating the Highway of ICD-10. We're going to be coding and focusing specifically today on diabetic conditions. Your objectives for today are to understand why proper coding is important, to learn who is responsible for applying and assigning diagnoses, to study guidance for coding diabetes and ICD-10, and lastly, we're going to apply that knowledge to common diabetes home health scenarios. On the next slide here, we're going to talk a little bit about the comparison between the structure of the ICD-9 codes and ICD-10 codes. And although we've gone over this in the prior webinar, I do like to go ahead and re-emphasize this because it's very important to know a little bit about the code structure and also the importance of who's going to assign codes. So you need to know a little bit about that. We're going to revisit a few of these points that we did in our last webinar for that reason. What I want to show you specifically on this slide is that the ICD-9 codes and ICD-10 codes structurally are quite different. For example, the codes in ICD-9 are 3 to 5 characters in length. So codes could be, like a 3-character code would be 311 for depression, a 4-character code would be 401.9 for hypertension, or 5 characters in length like 250.00 for diabetes mellitus type 2, unspecified or no complications rather. In ICD-10, however, those same code diagnosis codes can be 3 to 7 characters in length. You could have a 3-character code, a 4-character code, a 5-character code, a 6-character code, or even a 7-character code. And just like in I-9, how all the codes were not 5 characters in length, not all codes in ICD-10 are 7 characters in length either. So that again, I just want to re-emphasize that those codes can be anywhere from 3 to 7 characters in length in ICD-10. In ICD-9, the first character was always alpha or numeric, and the alphas that we used were E as in elephant and V as in violin codes, E or V codes. And then after the E or V code, all the other characters were 2 to 5, or in the second to fifth position rather. Those were all numeric characters. In ICD-10, the first character is always going to be an alpha. It'll always be A, B, C, D, all the way through Z, with the exception of the character U. The alphabetic character U is not used. It's just saved for later use or for code expansion in the future. The second character in ICD-10 will always be numeric, and then character positions 3 through 7 can be a mix of alpha or numeric characters. In ICD-9, again, we know the space for new codes was limited. That's why we retired the set. We didn't have room to continue to expand the characters and the codes to make way for the new technology that we have. In ICD-10, however, space for new codes is very flexible. We have lots of room to add new codes and new technology, new diseases, new terminologies in the future. Because of the space in ICD-9, detail was ambiguous, or I should say because of the limit of space in ICD-9, the new code space was limited and detail was ambiguous. However, in ICD-10, the space for new codes is very flexible, and detail for that reason is very specific. In ICD-9, we didn't have placeholders to deal with. In ICD-10, we do have some placeholders. The dummy placeholder X is already there in some cases, and in other cases, when we add the 7th character, sometimes we have to add the placeholder X before we can add the 7th character when the code itself is too short and requires a 7th character. So we're still comparing our ICD-9 and ICD-10 codes on this slide. In ICD-9, for example, we didn't have placeholders. In ICD-10, we're going to be using and do use a dummy placeholder X. Sometimes that placeholder X is already in its position, and in other cases, when the code itself is too short and it requires a 7th character, we will actually have to add X placeholders, and you may have to add 1, 2, or 3 in some cases, so that you can add that 7th character in the 7th position. The alpha characters in ICD-9 were case sensitive, which means if we didn't capitalize those, that our claims and our OASIS codes would reject. However, in ICD-10, the alpha characters are not case sensitive. It does not matter if it's uppercase or lowercase, those codes will still be viable codes. In ICD-9, of course, we didn't have laterality, and in ICD-10, we do have laterality in many codes. In ICD-9, you can see that there were just over 14,000 diagnosis codes. In ICD-10, we go up to just under 70,000 diagnosis codes. And thankfully, we don't have to deal with the procedure codes. As you can see here from our visual, we went from just under 4,000 codes for procedures in ICD-9 to almost 72,000 procedure codes in ICD-10. So there's actually 2 code sets. What we deal with in ICD-10 and home care is the ICD-10-CM set, and CM stands for clinically modified. There's another ICD-10 set called ICD-10-PCS, and those are procedure codes, which we do not use in home health care, so they won't be covered in the webinar series. Now, one last thing that's a little different between the 2 code sets, ICD-9 injuries are grouped by type. In ICD-10, injuries are grouped by the anatomical site. So let's again look at the code structure just a little bit. ICD-10 codes may consist of up to 7 characters, with the 7th character representing the visit encounter or the sequelae for injuries and external causes. So for that reason, you're usually only going to use that 7th character when you have injury codes or external cause codes. And you'll notice on the right-hand side, the ICD-10 code, the etiology, anatomic site, and manifestation site makes up the 4th, 5th, and 6th position of the code, and if that 7th character is needed, it becomes an extension code in the 7th position. So with this next slide, we're going to talk about OASIS C1 and Coding, because we know whether we are a clinician in the field or whether we are a QA or a supervising staff, we know that the OASIS C1 and Coding goes hand in hand, and we need to figure out how they work together and what guidance we have in using coding in the OASIS. According to the OASIS C1 Guidance Manual, which is readily found on CMS's website, ICD-10 coding must follow the official guidance for coding and reporting. That's why we had a separate webinar altogether, the first of 12, which went over some of the highlights and points of the official guidance for coding and reporting, because ICD-10 codes must follow that guidance according to the OASIS C1 Guidance Manual. Now, it's developed by CMS. ICD-10 is developed by CMS and NCHS, which is the National Center for Health Statistics, and adherence to the code set is required under HIPAA. Now, the ICD-10-CM coding rules and sequencing guidelines must be followed in order for us to be filling out the OASIS properly. And so sometimes because of that reason, we get a little confused about, well, we want to make sure it's correct and we want to make sure that we're coding properly. So sometimes clinicians in the field will be quite hesitant about even trying to assign diagnosis codes. So what I want to demonstrate in the next few slides is why the field clinicians really must have an active part in assigning diagnoses. Whether or not you know the code is another story, but you really need to be active in figuring out what diagnosis needs to be primary and secondary, and then your coder can always assign the code itself. But we need to really know, as clinicians in the field, what our primary reason for being in the home is, and then any other problems that we need to treat. Now, when we're sequencing diagnoses codes on our OASIS, the rating for symptom control is not to be considered when we sequence primary and secondary diagnoses in column 1. So if you're looking at your OASIS question M1021 and 1023, you'll notice there's several columns going across the page on that OASIS question. And M1021A is your primary diagnosis, and M1023B, C, D, E, and F, and so on, those are your secondary diagnoses. And what we're saying with this bullet point, according to the OASIS C1 guidance manual, is that you may have, say, depression, and you may have CHF, and you may have diabetes, and they may have pneumonia. And maybe diabetes is ranked at number 3, and CHF is a number 2, and depression is a number 3. What they're telling us is that rating for symptom control is not to be considered when you're sequencing your primary and secondary. So how are you supposed to know what to sequence? Again, according to your OASIS C1 guidance manual, the primary home health diagnosis should be the chief reason the patient is receiving home health care. So your face-to-face encounter, you'll need to know what the doctor's written on the face-to-face encounter, the reasons that the physician or the non-physician provider has sent that patient to home health services. What is it they're wanting you to do? Focus on. That chief reason the patient's receiving home care should be your primary home health diagnosis. It should be the diagnosis most related to the current home health plan of care, and the only current diagnoses can be used in the primary or secondary diagnosis position. So we're talking again about your OASIS C1 in the M question M1021A. That diagnosis is the main reason you're in the home, what's driving the home health care, and it only can be a current diagnosis. Now, in the 1023B and C and D and E and F position on the M question 1023, those are secondary home health diagnoses. And what CMS defines in the OASIS C1 guidance manual as secondary home health diseases and diagnoses, those are comorbid conditions that exist at the time of the assessment. So even though we may not be referred into the home for these particular problems, if the patient has comorbid conditions that exist at the time of the assessment, and they are going to have some bearing on how the patient will respond to treatment, or they may interfere with the patient's progress, or they may factor in that progress in some way, those also have to be coded in the secondary home health diagnosis position. Now, all of those diagnoses in the secondary diagnosis column they're also actively addressed in the plan of care, or they have the potential to affect the responsiveness to treatment and rehab prognosis. So let's say that I'm primarily sent out to see this patient for wound care. Maybe they've had a dehiscence from a surgical incision, and the patient also has diabetes. Now, we weren't referred in for diabetes, but the patient has diabetes, and their diabetes control is very good. They know how to check their blood glucose on their glucometer 4 times a day. They are very well versed in their medication regimen for diabetes. They know their diet. They're keeping a diet journal. Why on earth would we have to code diabetes? Because according to the guidance here, that's still a comorbid condition that exists at the time of assessment. They don't get cured of diabetes. They will always have it. The treatment may be different, however. And we would need to address diabetes in the plan of care because diabetes does have the potential to affect their responsiveness to treatment and their rehab prognosis. If something happens and that patient's diabetes becomes out of control, it goes up and down, it gets in the 300, 400 range, for example, that dehiscence is not going to heal as well as it would for a non-diabetic person. So for those reasons, we are to go ahead and code any secondary home health diagnoses and also anything that's going to have a potential to affect their responsiveness to treatment. So, who can actually select the diagnoses? Should that be the person in the field? Should that be a person in the QA department? Who is actually picking and choosing and putting those diagnoses on our OASIS? Now, according to the OASIS C1 guidance manual on CMS's website, we understand that the patient's primary and secondary diagnoses must be made by the assessing clinician. So I don't know how else to say that. Medicare makes it quite obvious and makes quite the point of saying that the assessing clinician is the person who should be putting down what is primary and secondary for the patient's reason to be seen. And Medicare goes on to say that the clinician is expected to understand that patient's overall medical condition and care needs before selecting the diagnosis. So again, the assessing clinician, it's our job to go in and assess the patient, look at our referral paperwork or our research paperwork, coordinate with the physician and the physician's office and the staff, and come up with what it is from the face-to-face encounter, whatever else is going on with that patient. If it's a research, calling the doctor and letting them know what's changed. But it's our job to understand that patient's medical condition and decide what is the primary reason that we're going to be in the home on the initial cert period or going to be continuing to see the patient in the research periods. And then we need to select those diagnoses. Those diagnoses are based on our assessment findings, the medical record, and input from the physician. It goes on to say in the OASIS C1 guidance manual that the assessing clinician should record the primary and secondary diagnosis in M1021 and 1023. So, then it goes on to say that the coder can actually add the code after the clinician has determined the primary and secondary diagnosis. So, I may not know the code for diastolic heart failure, but I can write that in and then have the coder add the actual code itself. So different agencies have different policies and procedures in place to assure that they're meeting this guidance. If you don't have specific policies and procedures at your office that guide you to do things the way that CMS has it laid out in their OASIS C1 guidance manual, I would definitely recommend that you go ahead and revise those policies so that they match what CMS has proposed here, what they intend for us to do, and that you set up a process in which the coder, whoever does the coding for you, and the field clinicians can communicate and make sure that this happens properly. Now, when you get to the point where you're actually coding, whoever is the coder in your agency, whether that be field staff who've been trained or an actual QA team member who's a coder, you want to always start in the alphabetic index of your code book. And I do intend on using code books because the guidance that you have in the code book is not found on these little free online lookup things that you get. You can find different codes, even the crosswalks, all those different tools that are out there floating around. You can find codes, but it is literally not taking into consideration at all the patient's records, what's going on with the patient, and neither does it take into effect any of the official guidance from the ICD-10 code set. That's why the code book is so important. And I advise you to get a code book every year, add that to your budget, because they do revise the coding guidance every year, usually around October. So when you get your code book out and you're trying to figure out what code to assign, you need to always start in the alphabetic index first. Now, when you're looking in the alphabetic index, a dash at the end of the entry means there are additional characters needed to complete that particular code. You may also see guidance that says C or C also, and when you see that, take that as a command, not a hint, because sometimes there's more information at the place where it told you to C or C also. There may be more information or more pertinent information regarding the code there than there actually was at the initial entry where you looked. Now, once you found a code in the alphabetic index, the next step to make sure you ensure correct coding is to double check that code in the tabular index. Now, the tabular index is the second part of the book in most cases, but it's the part where the book is broken down into chapters, and those chapters are laid out usually by system or etiology. So you're going to look in the tabular index for that particular code, and then you're going to check for guidance in 3 different places. You're going to look at the chapter and the chapter block level. What does that mean? Let's say that you're looking up hypertension, and you need to look at code I-10 to I-15. Those are all the hypertension codes. You have hypertension, you have hypertensive heart disease, you have hypertensive heart with chronic kidney, and hypertensive chronic kidney disease, and so on. Now there's guidance right at the top of I-10 to I-15. That's the chapter block level. There's more guidance at the 3-character category level, say at I-12. And then finally, at the final code level, if you get to say I-12.3 or whatever, sometimes there will be guidance there. And you need to check for each of those spots to see if there's guidance. At the chapter block level, for example, at I-10 to I-15, there's guidance that tells you that you should code also, or use additional code, rather, to use tobacco, or if the patient's ever used tobacco in their past, they have a history of it and so on, that you need to code that as well. So you'll need to check for that guidance in your code book. Now, when you're talking about coding criteria, when you try to select the correct code, you need to consider the following criteria. Number 1, that code must comply with coding guidelines. We are to code only unresolved diagnoses. What does that mean? That means if the patient went into the hospital because they had gallstones or cholelithiasis and they had their gallbladder removed, once that gallbladder has been removed, the cholelithiasis has been resolved, and so we would no longer code cholelithiasis in home care, because that is now a resolved diagnosis. And what we might see the patient for would be aftercare on the GI system at that point. It also tells us to code only the relevant medical diagnosis. My patient might have had some kind of gynecological issue. Maybe they had neoplasm in situ on a pap smear. And that has nothing to do with what I'm doing with home care, which is taking care of an abdominal dehiscence from where the patient had to have a bowel resection, for example. So we wouldn't code that because it's not relevant to what we're doing. Code only the relevant medical diagnoses. The next bullet tells us we're to code only diagnoses supported by the patient's medical record documentation. Now, when CMS is talking about medical record documentation, they're not talking about where we jot down what the patient said in their patient history verbally. What they're talking about here in the patient's medical record documentation, that would be documentation either from the provider or the physician, or information that we've had to query and get from the doctor or the provider. So let's say that the patient gives me on a verbal report at start of care that they have COPD, but we have information from the physician's office that they have asthma, okay? What would happen in that case? Our medical record documentation would not support that the patient has COPD. So what do we have to do? We have to call and query the provider and find out specifically what is the correct diagnosis. And once we get that information, we can then document that on either a physician's order or a communication note or whatever, whatever your policy is, that we spoke to Jennifer Gibson, RN, at Dr. Timothy Shepard's office on December 15th at 12 noon, and Nurse Jennifer confirmed that the patient does indeed have chronic obstructive asthma. So we get a new diagnosis, we record that in our records. Now the medical record supports the documentation if we add chronic obstructive asthma as a diagnosis on our OASIS. We also need to ensure compliance with sequencing requirements. There are some codes in coding in ICD-9 and 10, but we're talking about ICD-10 today. There's some sequencing requirements that tell you, for example, with manifestation codes, the underlying etiology would be coded before the manifestation. So, for example, if you had Alzheimer's disease and dementia, you have to code Alzheimer's disease before dementia, right? So that's what it's talking about with sequencing requirements. And then you have to make sure the etiology and manifestation codes are sequenced and reported properly, and avoid non-specific or ambiguous diagnoses and symptom codes when possible. Now, there will be times when you have to use symptom codes or vague codes. Maybe there's not a final diagnosis available. Maybe all that you have at that point is symptoms. And if that's the case, certainly that may be all that you can code. But you certainly need to try and query and find out more information, more specific information when it's at all possible. Now, how do we decide what's primary diagnosis? So we've kind of learned that the clinician in the field, we need to be figuring out what is the reason we're there in the home, and we have to assign that primary diagnosis. So how do you figure that out? The criteria that CMS gave us is right here. Thankfully, we will be able to figure out what we're supposed to be doing here. The primary diagnosis is most related to the current home health or hospice plan of care. If more than one diagnosis is being treated, then it's the diagnosis that represents the most acute condition and requires the most services that should be assigned as primary. Now, you have to make sure that matches your face-to-face encounter, though, right? Because nothing would be a bigger red flag to CMS than reviewing a chart at ADR, and we know certainly there's a probe going on right now, and ADRs are being sent out to all providers for home health services. And that's related to the face-to-face encounter reg changes, but they can certainly audit and or deny for any reason. So if CMS looked at the face-to-face encounter information and the doctors got written down on the face-to-face, they've documented that the patient needs services for something specific on that, and then you turn around and look at your plan of care and your OASIS, and the primary reason for home care or the primary diagnosis is something completely different, that's a big red flag to CMS. So certainly you need to make sure that it matches your face-to-face encounter and certification documentation. Usually the primary diagnosis is going to be the chief reason for home care or hospice, and it requires the most intensive skilled services. So usually it's going to be the one that has the highest frequency. For example, if you're in for wound care and the nurse is going once a week and then PT's going 3 times a week for muscle weakness, we have a problem. We need to see what's going on with that. It's not a Z code unless it's absolutely necessary, and that's using that 1025B for home health care. So just like when we used ICD-9, if you had a V code, which was usually going to be aftercare or something like that, that replaced a diagnosis code that was a payer, we would put over in 1024B the actual diagnosis code itself. This is not going to come into play in ICD-10 quite as much, but if it does, we might use a Z code in ICD-10 for the aftercare of a GI surgery, for example, and then over in 1025B, we might add, for example, the cholelithiasis over there, just to explain what was going on, that has been resolved, and we're actually there to see the patient for aftercare of the GI system. That's one I can think of right off the top of my head. And by the way, that column, 1024B in ICD-9 OASIS and 1025B in the ICD-10 OASIS, those columns over there are not used at all for payment or risk adjustment or anything. It's just to kind of explain what's going on with the patient, okay? For your secondary diagnosis sequencing, when you're going to select the secondary diagnoses, these are the ones that go in 1023B and C and D and so on. We are to consider the following criteria. The diagnoses that didn't meet criteria for primary, so they're not the most acute, they don't require the most intensive services, those are the things that will go in secondary diagnosis position. The diagnoses selected are addressed in the plan of care, and they affect the patient's responsiveness to treatment and rehab. Now, we certainly know that our topic today is diabetes, and there will be many instances where we code diabetes somewhere in a secondary diagnosis position, because no matter what's going on with that patient, diabetes definitely will affect their responsiveness to treatment and rehab in most cases. Now, as far as the secondary diagnoses, anything after that first initial primary diagnosis, anything there can be sequenced to best reflect the seriousness of the patient's condition and to justify the disciplines and services provided. So the sequencing there is a little bit different in that unless you have guidance in the ICD-10 code set that tells you must sequence one diagnosis before or after the other, you can shift those around otherwise based on acuity, okay? So now that we've covered the highlights of coding in general and who's supposed to do the coding and all of that, let's get specific about diabetes and how we're going to code diabetes in ICD-10. Now, in ICD-10, the diabetes codes are combination codes, and they include the type and the complication in one code in most of the instances that we see. The identification of controlled and uncontrolled does not exist in ICD-10, so that's one big change. We don't have to worry about having a physician statement that the diabetes is uncontrolled to code in ICD-10. We're also told in the guidance for diabetes coding to assign as many codes as needed to identify the associated conditions. So, if your patient's been diabetic for a number of years and they have diabetic neuropathy and they also have diabetic retinopathy, and maybe they have some kidney function issues due to diabetes, we are going to code all of those conditions and assign all of those diabetes codes to identify those conditions. But then we'll sequence those according to the reason for the encounter. So the physician may have referred this patient to home health care more along the lines of getting them some OT and PT and nursing because the retinopathy has gotten bad enough that the patient's not safe in their environment when they cook and dress and bathe and all of that. So we need to go in and adapt the environment and teach the patient on how to safely perform their ADLs with the vision loss. So in that case, the diabetes with retinopathy would go higher than the neuropathy and the other diabetes codes in that case, okay? So what types of diabetes in ICD-10? There are actually 5 classifications of diabetes in the ICD-10-CM code set. There were only 2, as you know, in ICD-9. We had our 249 and 250 classifications. But in ICD-10, we have 5. E08 is diabetes due to underlying condition. E09 is your drug or chemical-induced diabetes. E10 is diabetes type 1. E11 is diabetes type 2, and E13 is diabetes in other conditions such as a post-pancreatectomy patient. Now, I'll give you a little hint on how I remember these diagnosis categories. I start with E10. There's only one number 1 in E10, so that's diabetes type 1. There are 2 number 1s in E11, that's diabetes type 2. E13, you think about an unlucky 13, well, the person who has their pancreas removed is a pretty unlucky fellow, so that's E13. That only leaves me E8 and E9. E8 is due to an underlying condition, and E9 is chemical induced, okay? That's kind of how I remember those. So let's get specific about the guidance regarding the types of diabetes in ICD-10. One of the first things they tell us in the official guidance is that age or insulin use is not the determining factor in choosing the type of diabetes code. As a matter of fact, it goes on to tell us our default rule, and we think about guidance as the rules that we have to apply to get the correct answer. I think of coding in that respect almost like doing advanced math. If you've ever taken Algebra 1 or Algebra 2 or geometry or trigonometry and so on, there are certain math computation rules in formulas that you have to add and factor in and use properly. And if you don't do that, you'll get an answer, but it certainly is not the right answer, right? So ICD-10 coding is kind of the same thing. We have certain rules that's called guidance and conventions, guidelines and conventions, and those are the standard rules for getting the right codes. If you don't use these guidelines and conventions properly, you'll get a diagnosis code and you may sequence it, but it will be either the wrong code or sequenced incorrectly. And so you're going to shoot up little red flags when that happens. One of those rules is the second bullet point here in the ICD-10 guidance for coding. It tells us if the type of diabetes is not stated in the medical record, the default is diabetes type 2, even if that patient uses insulin. Now, when you're in my webinars or seminars live, quite often you'll hear me talk about urban legends of home health. And one of the urban legends that I see quite often in home health care would be that the patient is assessed and they have insulin, and lo and behold, this patient may have become diabetic at 45 years old, and they're now on insulin, and the next thing you know, the coder has assigned a type 1 diabetes code for diabetes type 1. In actuality, that should have been a type 2 diabetic. So the default tells us in the guidance, if the record does not say that it's type 1 or type 2 or whatever, our default automatically will be diabetes type 2, even if the patient uses insulin. Now, why does that make sense? Not every patient who uses insulin is insulin-dependent diabetic. That's a type 1 diabetes mellitus. As a matter of fact, when I used to teach my patients in the field about diabetes and insulin and all of that, one of the analogies that I came up that made it easy for them to understand was that insulin acts as a key that unlocks the lock so that your body can unlock the doors and let the glucose or the sugar out of the circulatory system and into the cells to feed those cells so they can continue to live and grow. Now, a patient who is truly insulin dependent, type 1, their body makes no keys at all. And so they have to take insulin to unlock all the little doors and make sure that their body is fueled by their glucose. And a patient who has diabetes type 2, their body may make keys, but either the keys don't fit the locks properly or they're not making enough insulin keys to handle the demand that the body has. So in that case, patients sometimes will have to take supplemental insulin to either add additional keys or add keys that fit the locks in their body. So for that reason, all of that physiology, CMS takes all of that into consideration, and the coding clinic and the code set and all of that. And that's why they tell us if the diabetes is not stated in the medical record, the default is type 2. Now let's look at the secondary types of diabetes. These replace the 249 codes in ICD-9. Two of the ones that we have are E08, diabetes due to underlying condition, or E09, drug or chemical induced diabetes mellitus. And the E9 codes, they're always caused by another condition or event. What are some examples of that? An example of an E08 code, diabetes due to an underlying condition, that would be if the patient has, say, cystic fibrosis, or they have a malignancy of their pancreas. And for that reason, the body's not functioning properly, and that's thrown them into being diabetic. E09, a drug or chemical-induced diabetes mellitus, an example of that would be an adverse effect of a drug or poisoning from a drug. These diabetics, quite often when I was young and out seeing patients in home health care, actually did that for quite a few years, about 20 years to be exact, I would have patients who told me, oh, I'm not diabetic. I just have high blood sugar because of my rheumatoid arthritis. I have to take this prednisone, and after all those years of taking prednisone, my blood sugar's high. There's actually a category for that, and that is the E09 adverse effect of drug or poisoning. Now, we're going to talk a little bit about what the difference is between adverse effect versus poisoning. The use of, and we'll get to that in just a moment. As far as the use of insulin, we have guidance that tells us to indicate if the patient uses insulin or not. And if they do, we're going to also code a Z79.4, which is long-term or current use of insulin, but we are instructed not to use that with our E10, which is diabetes type 1 patients. And why is that? Because everybody who's a type 1 diabetes mellitus patient, they all have to use insulin, so that would be redundant. We don't have to state that with the Z code. When we're sequencing our secondary diabetes in relationship to the cause of the diabetes itself, those particular things are sequenced according to instructions for category 8, 9, and 13. Now, I want to say this particularly to those of you who are just using mappings or GEMs or some kind of pick list and you're not using a code book. You're going to notice in the next few slides, if you've had to code these particular patients without a code book, you're likely sequencing them wrong because each one is different depending on what's going on with the patient and the guidance. Sometimes the diabetes code goes first and sometimes another code goes first according to the official rules and guidance for the code set. So we're going to get into that particularly in the secondary diabetes codes at E08, which is due to underlying condition, E09, which is drug or chemical induced, and E13 is that other reasons for having diabetes, like having your pancreas removed. If you're in your code book and you flip over to category E08, you're going to notice there's some instruction that says code first the underlying conditions such as congenital rubella, Cushing's syndrome, cystic fibrosis, malignant neoplasm, malnutrition, pancreatitis, and other diseases of the pancreas. And then there's another layer of guidance that tells us to use an additional code to identify any insulin use. What does that mean? Let's say your doctor referred the patient to you because they have cystic fibrosis and they are now also diabetic. Their blood glucose is high. The patient needs to be taught on the use of the glucometer and how to give their insulin and about their diet. And they've never had diabetes before. So your face-to-face encounter will say, perhaps home health skilled nurse to instruct patient on diabetes, due to cystic fibrosis, needs glucometer training, needs insulin teaching, needs diet teaching. It may be really specific like that. So if you look back at the guidance that we just talked about selecting primary and secondary diagnoses, our knee-jerk instinct would be to put the E08 diabetes code first, right? However, we have to also look back at the OASIS C1 guidance manual that tells us that we have to code in sequence according to the guidance and that we have to follow the guidance for OASIS. So you're weighing that out. Which do I do? You have to follow the coding guidelines. And the coding guidelines in this case tells us that we are to code first the underlying condition. So in that particular case, we have to code cystic fibrosis, which is an E84 code, before the E08 diabetes due to underlying condition code. And in that case, we are both following all the rules. It will line up with our face-to-face encounter. It's going to line up with the coding guidance and everything else because we are following the coding guidelines and conventions. Now, there's also an excludes one note at E08. And excludes one, as we remember from the prior session 1 of our 12-part series, an excludes one note is like a stop sign that says you can't code these particular problems that come after the excludes one note and the E08 diabetes due to underlying condition codes together. And if you look at these particular codes in the excludes one note, it kind of makes sense why. Because excludes one is saying you can't code drug or chemical induced diabetes with diabetes due to underlying condition. Why does that make sense? Because a patient is not going to have more than one type of diabetes mellitus. As the way it is defined today, you can't have a type 1 diabetes and a diabetes due to underlying condition at the same time. It's either caused by one or the other. So in this particular case, our patient has diabetes due to cystic fibrosis, not because their body makes no insulin whatsoever. That would be a different type of diabetes, okay? E08 diabetes due to underlying condition, some other guidance that's in the ICD-10 code set. It tells us the underlying condition has to be stated by the provider being the physician or the non-physician provider as defined by CMS. Now, E08 codes, because of what we've just learned, they will never be primary diagnosis codes. So if in 1021A you're putting an E08 code first, you're coding incorrectly, because we've already learned that E08 codes have a note at the guidance that tell us to code first the underlying condition. So for that reason, E08 codes will never be your primary diagnosis code. The underlying condition is sequenced first, always, for E08 codes. All right, so let's do a little practice scenario to practice that E08 guidance. Your patient's referred for insulin administration training, glucose monitoring training, and to teach on the new onset of diabetes due to cystic fibrosis. Per the physician's documentation and your assessment, the patient's glucose is consistently over 300. How do you code and sequence this scenario? We already know that cystic fibrosis is primary, right? So we have E84.8 in position 1021A, that's cystic fibrosis. Then we have to code in 1023B, E08.65, which is our diabetes mellitus due to underlying condition with hyperglycemia. And then finally, because the guidance told us that we also need to use a code to indicate the patient takes insulin, we have selected code Z79.4, long-term use of insulin. All right, the next category of diabetes that we have is E09, drug and chemical-induced diabetes. This particular category is used for diabetes that's caused by the adverse effect of correctly prescribed medications, poisonings, or sequela of poisonings. What is sequela? Sequela, remember, is the underlying effects after the initial problem has healed. So sequela means that whatever's going on with the patient has resolved, and now we're seeing after effects of that particular poisoning. So in this case, the patient's body, they've gotten over being poisoned, but now they're having diabetes as a sequela. And that's an E09, drug and chemical-induced diabetes. There's some guidance at E09 that tells us we are to first code poisoning due to a drug or a toxin if that's applicable. If the patient's not poisoned due to a drug or toxin, then we don't have to worry about that. It also has category guidance that tells us to use an additional code for adverse effect if applicable to identify the drug, and then use additional code to identify any insulin use. Now, if you haven't listened to our first webinar, you might want to go back and review that, because it gets specific about what is the difference between poisoning and adverse effects of drugs and so on. We're going to briefly brush over that as we continue with the diabetes guidance here, but for full understanding, you probably need to go back and listen to that first webinar. When a medication is actually causing diabetes, the clinician must find out if the drug is being given and taken as prescribed. Why is that? Because that is going to give us the indication as to whether this is an adverse effect versus a poisoning. Because if the medication is taken correctly, then that means it's an adverse effect. But if the patient's taking too much or too little, too much of that drug is poisoning, too little is underdosing. So let's say the patient has rheumatoid arthritis and they have diabetes due to their prednisone. The first thing that we have to go in and assess is, what is the prednisone dosage supposed to be? So we're looking at the order that they have. We're comparing the medication profile that was sent over with the referral to the prescription bottle. First of all, those two need to match, and if they do exactly match, we need to find out how the patient's taking the medication. Are they following the prescription? If they're taking too much medication, then they're actually going to be classified as a poisoning. If they're taking too little, that's an underdosing, and that's not applicable in this category. If they're not taking enough medication, that means we need to call the physician. If they're taking more than they should, we also need to call the physician, and while we have the physician on the phone, we need to let them know, hi, just wanted to let you know her prednisone dosage should be 1 tablet, she's taking 2. Just wanted to let you know, is it okay if I code this as a poisoning in this case? Because she's got drug and chemical induced diabetes. That should all be documented in your records. And if she's taking the drug exactly as prescribed, she's taking 1 tablet daily, then that's going to be an adverse effect. And the sequencing is dependent on whether or not it's an adverse effect or poisoning. That's why this is so important. So once you've deduced if the patient is taking it properly and having an adverse effect or taking too much, that's a poisoning, then we can proceed with coding an E09 drug and chemical induced diabetes. The first thing you're going to need to do is find your table of drugs and chemicals in your code book, and this table comes right after your neoplasm table. And the first thing you're going to do on the left-hand side of the page, when you get to the table of drugs and chemicals, that's where all of the drug names will be listed. And at the top, you're going to have columns that have the headings of poisoning, adverse effect, and underdosing. So the first thing you do is you find the drug name, and it's generally going to be a generic or even the drug classification. But sometimes, like with prednisone, you'll actually find the brand name. So you're going to find that drug name on the left-hand side of the page, and then go up to the top and find the correct heading, and where the drug name and the heading intersect, you can find the code. Just like in your alphabetic index, however, the code on that table is not a complete code. You're going to have to flip over into the tabular section of your book to confirm that code and add a 7th character in most cases. All right, so let's practice this scenario. Your patient's referred for teaching insulin administration, glucometer training, and teaching on the new onset of diabetes due to long-term use of prednisone for rheumatoid arthritis. Per the physician's documentation and your assessment, the glucose is consistently over 300 again in this case. At the admission visit, you notice that the prescription bottle states to take 1 tablet daily, but your patient's actually taking 1.5 tablets daily. You confirm with the physician the prescribed dosage of 1 tablet daily, and then you set up a medication planner. You teach the patient the correct dosage, and you continue your assessment. How are you going to code and sequence this scenario? So the doctor tells you that it's diabetes due to long-term use of prednisone. We already know this is an E09 drug or chemical-induced diabetes, right? Okay, so now we had to deduce whether or not the patient's taking the medication properly, and we noticed that she's not. Not only did we look at that with the medication bottle, but we also called the physician's office to make sure that he hadn't changed the dosage on the prescription bottle, and they said that it should be 1 tablet daily. And you notice the patient's taking 1.5 tablets daily. In this case, this is not an adverse effect because the patient is taking too much. In this case, it would be a poisoning, right? So we already know that it's going to be coded to category E9. We're going to go to the table of drugs and chemicals. We're going to look for prednisone on the left-hand side of the table, and then we're going to find poisoning at the top of the page. And by the way, in poisoning codes, you're going to have to choose if it's accidental or if it's an assault or whatever, or a known. In the guidance, we are told to assume that it's accidental unless the physician tells you otherwise. So, because we have now found poisoning accidental, we have found the drug prednisone where those two columns and headings meet. We're going to find that code. And remember, our guidance at E09 told us to code first the poisoning or to use an additional code for adverse effect. So again, this is how you know sequencing is going to be different depending on what's going on. In this case, we have at M1021A T38.0X1D, poisoning by glucocorticoids and synthetic analogs. In 1023B, E09.65, drug or chemical-induced diabetes mellitus with hyperglycemia. And last, again, we have our Z code to indicate the patient is using insulin, and that's Z79.4, long-term use of insulin. So in this case, the guidance at E09 tells us to code first the poisoning, if that's what's going on. So because it was a poisoning, that code would go first. However, what would you do if the patient were taking the correct dosage? So our answer would be different. If the patient were taking the medication properly as it's prescribed, the sequencing would be completely different because at E09 guidance it says use additional code for adverse effect. And so in that case, what use additional code means is that it's sequenced after the E9 code. So if the patient's taking the medication properly, in that case, E09.65, drug or chemical induced diabetes mellitus with hyperglycemia, that would actually go ahead of the T38.0X5D, adverse effect of glucocorticoids and synthetic analogs, subsequent encounter code, and then the long-term use of insulin code would still be Z79.4 in the third position. All right, our next slide, E10, is the next category of diabetes. This is our type 1 diabetes mellitus. Again, we've covered that a type 1 diabetic requires insulin to live because their body makes no insulin keys. Remember, not all insulin users are type 1 diabetes. We are not to assume that a diabetic who uses or is dependent on insulin has type 1 diabetes. The physician should be queried about any suspected manifestations. So if the documentation doesn't say that they have neuropathy due to diabetes, we have to query and see if it's related, document that, and carry on and so on. We're also told in guidance not to assume a young patient has type 1 diabetes. With the ongoing epidemic of obesity in our country, we are seeing young people with type 2 diabetes because of insulin resistance and such. So just because of the age, we are not to assume that if they're a young person that they have type 1 diabetes. We also know that we are not to code the long-term use of insulin with an E10 type 1 diabetic because those patients all require insulin, so that's redundant. The next category is E11. This is type 2 diabetes mellitus. Remember, it's our default code if documentation does not state what type of diabetes the patient has. Even if documentation goes on to say that the patient uses insulin, if we can't query and find out what type of diabetes and it's not stated in the medical records, our default will be type 2 diabetes. We are to use an additional code to identify insulin use with the E11 type 2 diabetes mellitus, and then you need to make sure you check the guidance in the entries for E10 and E11 for sequencing. For example, renal failure and ophthalmic manifestations and such as that. There will be guidance at the diabetes type 1 and diabetes type 2 with renal manifestations that will tell you, for example, to use additional code for the stage of renal failure, for example. All right, so let's look at E11.9. There's some information here that we certainly had when we switched over to ICD-10. We got a lot of calls here at Axxess on our support lines wondering why we were flagging and having some different issues with codes. And the problem was that agencies were using an E11.9 code and then other E11, like say 3 or .4 codes, and the guidance was kicking that out because there's guidance that says if you use E11.9 type 2 diabetes mellitus without complications, you can't use any other E11 codes because all the others are used for manifestations. For example, if you used an E11.9 type 2 diabetes mellitus without complications, and then you tried to use E11.621 type 2 diabetes with a foot ulcer, then you can't use both of those. You have to only use E11.621. So most of the reason that that kind of issue cropped up was because people were relying on crosswalks and not using code books and actually getting the guidance. So just know that if you use E11.9 code, you can't use any other type of E11 code. Let's get specifically about diabetes and wound care coding. Now, whether you're coding E11 type 2 diabetes or E10 type 1 or any of the other categories of diabetes, when you start talking about wounds, number one, the first thing we need to know is that we as clinicians cannot assume the origination of the wound. What does that mean? Just because I go in and see a patient who's diabetic and they have a wound on their toe, I cannot say that that's a diabetic foot ulcer. Only the provider can state the origin of the wound. Now, any kind of wound that's on the foot, that could be venous, that could be arterial, that could be a diabetic ulcer. So I can't just look at that and tell. I must have information from the provider. If they don't fax that over to us, we're going to need to call and query and find out what the origin of the wound is. Now, the clinician in the field will need the level of tissue involvement to properly code the diabetic ulcer and other wounds. And what does that mean? The codes get very specific as to whether this is just a break in the skin, whether the fat layer is exposed, whether there's muscle necrosis or bone necrosis. And in the ICD-9 environment, we didn't have to be that specific, but in ICD-10 we do. So make sure clinicians are documenting on all of their ulcers. And this is not pressure ulcers we're talking about. These are all the types of non-pressure ulcers, including diabetic wounds, whether or not it's a break in the skin, the fat layer, or if there is muscle or bone necrosis. All of that should be documented. Another big change is that there is no assumed relationship between diabetes and osteomyelitis in ICD-10. And I've got this headed under an E11 type 2 diabetes, but this applies for all diabetes codes. Again, there's no assumed relationship between diabetes and osteomyelitis in I-10. In ICD-9, that was an assumed relationship, and you coded it no matter what, but in ICD-10, that's not true. If the patient has diabetes and osteomyelitis, the physician or the provider has to connect those two conditions in their documentation. So they may say something like diabetes with osteomyelitis or diabetic osteomyelitis. That lets you know that they've connected it. Otherwise, if they just say the patient's diabetic and the patient has osteomyelitis, you're going to code those two separately. If the doctor does connect diabetes and osteomyelitis, then you'll code this to diabetic osteomyelitis E11.69 if it's a type 2 diabetic. And that code in specific is type 2 diabetes mellitus with other specified complication. Now, if your patient is not a type 2 diabetic, they're type 1 or E08 or E09, you're going to choose the applicable code as well. It would be, drug-induced diabetes with other specified complication and so on. And then after that E11.69 code, you'll add an additional code for your osteomyelitis right after that to show the connection, okay? Let's practice that scenario. The physician sends a referral for a diabetic patient who has a wound on his left great toe. The clinician's assessment shows that the wound has fatty layer exposed. A skilled nurse is ordered for wound care and to teach on the use of newly prescribed Lantus insulin every evening. How would you code this? Number 1, what do we know? The diabetic patient has a wound on the left great toe. Do we have anything here that tells us that the wound is due to diabetic or it's a diabetic ulcer? We don't. So the first thing we're going to have to do is query. Got to call the physician, and the physician does say, yes, it is a diabetic ulcer on the left great toe. So now that we have that information and the assessment telling what level of breakdown we have here, we can now code this patient. We also do not know what type of diabetic we have, right? It just says a diabetic patient. Do we code this to category E08, E09, E10, 11, or 13? Well, since we don't have this stated, if we didn't find out on our query, we're going to default to type 2 according to our guidance. So we need to find out what type of diabetes the patient has, what is the origin of the wound, and the query to provider only provided us that this is a diabetic ulcer. They didn't tell us what type of diabetes. So for that reason, we have in 1021A our E11.621 code, type 2 diabetes mellitus with foot ulcer. There's guidance there that tells us we need to use an additional code to show the location of the ulcer, and that at 1023B is L97.522, non-pressure chronic ulcer of other part of left foot with fat layer exposed. Again, notice you have laterality here. You also need to know what layer of tissue is affected, and we have that. And then lastly, we are to code also the long-term use of insulin on all the patient types of diabetes except for E10, and so for that reason we're going to use Z79.4 long-term use of insulin. All right, the last category that we have in ICD-10 diabetes coding is E13. That category is titled Other Specified Diabetes Mellitus. Now we have guidance here to use additional code to identify the insulin use on these patients. And it tells us if diabetes is caused by a malignant neoplasm, we need to query the physician. And what do we need to find out and why? We need to find out if the neoplasm itself is causing the diabetes. If that's the case, we're actually going to code that to category E08 instead of E13. If we find out that the diabetes is caused due to the drugs that are being used to fight the neoplasm, again, that's a different category. That's E09, drug-induced diabetes mellitus. But finally, if the diabetes is caused because the patient had a neoplasm of the pancreas and that pancreas was then removed, that would be a proper assignment to category E13, the post-pancreatectomy patient. Thus, the unlucky fellow who has an E13 post-pancreas diabetes, okay? So if we're going to code a pancreatectomy, we have to code three things. Number one, the lack of insulin due to the removal of the pancreas. In that case, we're going to assign E89.1, post-procedural hypoinsulinemia, and this is in the guidance. And then we also assign the code from E13 category. And then last, we're going to code the subcategory Z90.41, acquired absence of pancreas. And then we would also have the Z code for long-term use of insulin as well. So let's practice this scenario. We have a physician who sends a referral for home health nursing to admit a patient who had their pancreas removed 2 years ago for malignant neoplasm. The patient has diabetes due to removal of the pancreas and now has stage 1 renal failure because of the lack of control. Patient needs diet teaching and assessment of insulin compliance. So what do we need to know here? Number one, what is the actual cause of diabetes? It was not due to an underlying condition because the E08 would be if the neoplasm itself is causing the problem. We know the neoplasm in the pancreas has been removed, so it's on an E8 category. We also know that it's not due to drugs or chemicals, not getting chemo or anything like that, so that would not be an E09 category. It's not a true type 1, E10. It's not a true type 2 diabetes, E11. This is going to be due to what? Removal of the pancreas. So that is the unlucky fellow at E13. All right, so let's look at what we coded. In 1021A on our OASIS, we have E13.22, other specified diabetes mellitus with diabetic chronic kidney disease. There's guidance at that code that tells us to use additional code to identify the level of kidney disease, what stage they're in, and so we chose N18.1 for chronic kidney disease stage 1. We had to add the two codes, the Z codes or status codes. Z90.410 is the acquired total absence of pancreas, and Z79.4 is our long-term use of insulin. So that would be how we code that particular patient. All right, so putting it all together, we've learned or we now understand why proper coding is important. It's important, number one, because CMS expects us to use the guidance and conventions of ICD-10 coding on our OASIS. We've learned who's responsible for applying and assigning diagnoses. The assessing clinician has the responsibility of deciding which diagnosis is primary and which is secondary. And the coder can add the actual code, the characters, but we have to decide as clinicians what code needs to be primary and secondary. We've studied the guidance for coding diabetes in ICD-10, and then we have applied our knowledge to common diabetes home health scenarios. I hope that you've learned a lot today. I hope that this has helped you with your coding and diabetes and understanding. Please know that part 3 of this webinar series is coming soon. We're going to continue exploring different disease processes and body systems and the guidance that goes with each. And I look forward to helping you succeed in all of the different body systems and coding as we go forward. Again, my name is Jennifer Gibson. I'm a registered nurse. I've been in the home health field for over 20 years, and I've been with Axxess almost 4 years. It'll be 4 years in the upcoming summer, and I really enjoy what I do, and I hope that I can continue helping you. In the meantime, if you have any questions, please get in touch with me. You see my phone number here with the extension 3917. You can leave a voice message. I'm often traveling and quite often may not be able to pick up the phone. But if you leave a message, I'm certainly happy to get back with you. You can also email me at jgibson@axxess.com. And quite often, if I'm in a meeting or I'm traveling or whatever else, I can usually answer those emails quite quickly. So feel free to give me a phone call and leave a message or send me an email, okay? It's great to be working with you today, and I hope you have a wonderful evening or morning or whatever time of day that it is. Enjoy your day, and thank you for what you do. No matter what position you're in home health care, we know that without you, there would be patients who don't get the care that they deserve at home. So I do want to emphasize that we here at Axxess appreciate all that you do to provide for our homebound and disabled patients. Okay? Have a wonderful day. Bye-bye.
Thank you for joining our webinar today. We know that your time is valuable and are happy you chose to spend it with Axxess. Axxess is proud to offer a variety of resources to supplement your training and keep you in the know of industry news and updates. You can register for additional training webinars through our software or sign up to attend a live seminar on Axxess.com. We also provide tutorials, online training manuals, frequently asked questions, and on-demand videos through Axxess.com. Our expert support representatives are from this industry and have been in some of your shoes. If you'd like to speak directly with one of our representatives, we are just a call or a click away. You may call us at 800-795-5900 or email us at support@axxess.com. Now that we've given you all the great tools to make you an expert, join the conversation and connect with us on Facebook, Twitter, Instagram, Google+, and LinkedIn. Here we will keep you in the know with industry news and Axxess happenings. Thank you for your time today and for choosing Axxess, your partner providing the knowledge that empowers you to grow your business.